From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. And today I'm speaking with Dr. Laura Koskenvuo and Dr. Ville Sallinen, and they are from the Department of Gastroenterological Surgery at University Hospital and University of Helsinki, Finland. Welcome to both of you.
Hello, nice to be here.
Thank you for having us.
Our topic today is morbidity after mechanical bowel preparation and oral antibiotics prior to rectal resection. The role of antibiotics in bowel preparation has been controversial for a long time, as you all note in the introduction to your manuscript. What motivated you to look at this very specific question of morbidity following elective rectal resection with primary anastomosis?
Our motivation stemmed from the practical clinical interest to treat our patients with rectal cancer better. There were some randomized trials about oral antibiotic bowel preparation in general in colorectal surgery. But actually, and perhaps surprisingly, outcomes were not reported separately for rectal surgery. Rectal surgery differs from colonic surgery as the low colorectal or coloanal anastomoses are in general riskier than colonic anastomosis. Neoadjuvant treatment is often used and protective stomas are frequently performed.
So we were really surprised that we didn't find any difference in our previous Mobile 1 trial, which included only patients with colon resections. And as Laura just said, rectal surgery is more prone to complications, so we thought that oral antibiotics might have a bigger effect in that type of surgery, and this motivated us to dig deeper in just patients undergoing rectal surgery.
I'm glad that you mentioned the Mobile 1 trial, because my next question relates to a key difference between this one and that one. You chose to have two arms for this study, using an arm that was mechanical preparation with and one that was a mechanical preparation without antibiotics, and to not have an arm with no bowel preparation. And as we were alluding to with the Mobile 1 trial, there was a no preparation arm in that study. What was the reason that you chose to not include an arm without any preparation for this trial?
Yeah, that's a really good question. That actually could have been an option. We were thinking about setting up the trial initially with 4 arms. That would be no preparation, oral antibiotics alone, mechanical preparation alone, and then the 4th arm would be the oral antibiotics and mechanical preparation. The thing is that this would have meant a far larger sample size, which wouldn't have not been feasible to conduct in a reasonable time frame. So we needed to stick to 2 groups. This was heavily discussed within the study group, and we also took into consideration the standard practice worldwide at the moment.
There is at least one randomized trial of benefits of mechanical bowel prep in rectal surgery. And in rectal surgery, the bowel is in general mechanically prepared nowadays. Protective stoma is often used, and bowel between the stoma and the anastomosis is preferred to be empty before creating the high-risk anastomosis and the protective stoma. This is different from colonic surgery, where the bowel is not routinely, or at least as routinely, prepared. One study dealt with colonic surgery in which the bowel preparation is not considered to be necessary anymore.
One of the things that immediately stood out to me when I started reading your manuscript was the date of the study initiation, because the World Health Organization declared the pandemic on March 11th of 2020, and your study opened for enrollment exactly 1 week later.
Yeah, that's true.
It was one of those things that I looked at it and I said, wait, that timing seems terrible. So I'm curious if there were any aspects of the trial that were impacted by the pandemic.
In Finland, the beginning of pandemic was maybe not as dramatic as in some other countries, and treatment of patients with rectal cancer continued throughout the pandemic time. Operations of patients with rectal cancer were not cancelled, perhaps partly because these are the patients who very seldom require intensive care postoperatively. The trial initiation was also planned long before the pandemic started, and it was obviously only a bad luck that the initiation of the study dated at the same time.
It was actually quite close that we would have needed to postpone the trial. It was only some days or some weeks after the trial started that our hospital management prohibited starting new trials due to the pandemic. However, we just started it a little before that, and we were able to run the trial more or less normally, and the pandemic didn't affect the trial actually in any way. Finland was quite proactive in setting restrictions in the beginning of the pandemic, and thus the hospital was running quite normally for major cancer surgery.
That's wonderful that you all were able to proceed as planned for something that's so important like this work. So, pre-specified subgroup analyses are not always terribly important, but for your study, they proved to be quite interesting. So, I did want to call readers' attention to Table 2 and the supplementary tables. I know that you mentioned in the manuscript that there was the possibility of a type 2 error, but it was striking to me that for each subgroup analysis, that the difference between the control and the study group was significant for one of the groups and not the other. Do you all have any thoughts about why this might be the case?
The power calculation was made only for the two main arms, obviously. All of these subgroups with significant difference were the subgroups with most of the patients included in. So the power seemed to be enough for those subgroups. Then on the other hand, in some subgroups, the differences were not statistically significant, and these comparisons might suffer from type 2 error, which is due to small number of the patients in these groups.
So the subgroup analysis point that oral antibiotics are effective, especially in patients undergoing open surgery with ultra-low anastomosis and protective stomas. Our results, on the other hand, leave some doubt whether oral antibiotics are also effective in other patients undergoing rectal surgery, such as patients who undergo laparoscopic surgery with higher anastomosis and those without the need of a stoma. However, I think it's likely that oral antibiotics are effective also in these patient groups, but the subgroups are just so small that the power is not enough for these.
That was my impression looking at the results, was that there's a very strong signal that the oral antibiotics probably play an important role, but it's just not what the study was designed to answer. Was there anything that was particularly surprising to the two of you as the investigators during the process of the study itself or during your analysis of the data?
Setting up the trial was relatively straightforward, as we already had processes for such trial in place, as we had just finished the Mobile 1 trial. Patients were in general interested in joining the trial, and recruitment was relatively easy. The most difficult part was the manufacturing of the placebos, which needed to be identical to active tablets. Also, neomycin was not readily available in Finland in tablet form, so it needed to be imported with special permissions. And as for analysis, we were surprised by the fact that the difference in our main outcomes, complications, anastomotic leaks, and surgical site infections were so prominent. Mobile 1 trial did not yield a significant difference, so we were delighted that we could show a benefit of oral antibiotics in this Mobile 2 trial.
How have your findings impacted your clinical practice?
The current practice in Finland, at least before the trial, was not to use oral antibiotics for patients coming to rectal cancer surgery or for any colorectal surgery for that matter. We think that the results of this trial will change this practice immediately once it's published. The antibiotics, the neomycin and metronidazole used in this trial, they are very cheap, only some euros or less than 10 euros anyway. And based on the results and number needed to treat calculations, it's about 13 patients that would need to get the oral antibiotics in order to prevent one anastomotic leak. And as anastomotic leaks cost several tens of thousands of euros to treat, so by spending approximately 100 euros, you can prevent a complication costing tens of thousands of euros. So it's really a no-brainer to start using them immediately. All the study centers in Finland already have started using them, and we anticipate that others will follow as the results will be published.
I am not surprised that this was a rapidly practice-changing study for you all once you became familiar with your findings. Dr. Koskenvuo and Dr. Sallinen, thank you both so very much for your time today. I really appreciate you giving us the opportunity to learn more about your work.
Thanks for the invitation. It's been a pleasure.
Thank you. It was a pleasure.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.